So we are here to discuss a new molecule in the antidepressants known as vortioxetine. It has a special features. So we will discuss what are those features in the next few slides. So starting with the background of depression, you all are very versed that it's a syndromal disorder which has affective symptoms as a core feature. A patient with depression can have pathological sadness, easy fatigue, irritability, subjective feeling of distress, cognitive impairment, worthlessness, hopelessness, helplessness, and somatic symptoms. So the key numbers are globally 5% of adults are suffering from depression, and in Indian perspective 3.3 adults uh, are suffering from depression, comprising of 45 millions of patients. So it has a heterogeneous disorder. The domains are emotional, cognitive, and physical. In emotional domain, you all know that sadness, anxiety, irritability, lack of enjoyment, etc. are there. In cognitive domain, impairment in attention and concentration, impairment in memory secondary to impaired concentration, impairment in judgment, decision making, and speed of decision making are affected. In physical symptoms, here is fatigue, weight changes, impairment in sleep, sexual dysfunctions, psychomotor agitation, pain, abdominal problems, headaches are there. So for the diagnosis, as per DSM-5, 2 out of these depressed mood or loss of interest is required. And in the minor features, out of 7, 4 is required, which are change in weight, sleep disturbance, psychomotor agitation or retardation, fatigue, worthlessness, guilt, executive dysfunction, and suicidal ideations. So the dysfunctional brain areas in depression, uh, look at the middle of this picture. There is normal mood, and on the left side there is reduced positive affect, which is uh, result of dysregulation of norepinephrine function and dopaminergic functions. On the right, there is increased negative effect, which is result of dysregulation of norepinephrine and serotonin. Now look at this picture uh, depicting the basis of depression. This is pre-synapse from where amino acid precursor converts into neurotransmitter through enzymatic reactions, and these are stored in vesicles. These small balls are neurotransmitter which are released when electrical impulse comes from the presynapse, and it executes function through this postsynaptic receptor. So in the middle, this is synapse, which has uh, the space which is the space between presynapse and postsynapse. And at presynapse, this is orange colored the thing which you can see is specific transporter for the neurotransmitter. And this triangular shape picture is autoreceptor. The function of this transporter is to transport back this neurotransmitter into the presynapse, and which is metabolized by MAO. And this triangle shaped figure is autoreceptor, which signals the presynapse that there is excess of neurotransmitter in the synapse. So you stop releasing the neurotransmitter further. So this is the basis of execution of neurotransmitter, which ultimately uh, execute the emotions and functions of emotions through gene expression. The last, what happens in depression is there is either increased degradation or decreased synthesis of neurotransmitters, or there is dysregulated activity of transporters, or there is disturbed affinity of pre and postsynaptic receptors for neurotransmitters. Now see the course of major depressive disorder. Here is on the left, you can see there is no depression, and the person lands up into depression. And here the treatment phase starts. This is the acute phase, this is continuation, and this is maintenance. In acute phase, when the patient is improving, may relapse again into the depression, or sooner after in the continuation phase. When there is relapse, relapse can occur in acute and continuation phase. When there is a phase of remission and recovery, when the patient uh, land up into the depression from recovery phase, it is called as recurrence. It can happen in maintenance phase also. So these are the few scales for screening the depression. One is Hamilton Depression Rating Scale, MADRS, CDRS, and self-rated instruments are Back Depression Inventory, Geriatric Depression Scale, CESD, PHQ, and GBI. These are the common scales which are used in the clinical practice. So, what are the treatment options available for a depressed patients? Are antidepressant medications, can be cognitive behavior therapy, family therapy, other therapies like interpersonal therapy, group therapy, and supportive psychotherapy. And in stimulation therapy, we can give electroconvulsive therapy, transcranial stimulation therapy. So this is the course of major depressive disorder, which says 50% of persons recover with no further episodes. So for the lifetime, 50% of patients have only one episode. 35% experience recurrent depression, 15% experience unremitting depression. So while you are treating the depression, how will you look uh, for the treatment success? So see, in the 70s, the treatment success was defined as reduction of symptoms in MADRs by lesser than 50%, and same for the HAM-D score. In 1990s, the concept of remission came, which says MADRS score should be less than or equal to 10, and HAM-D score less than equal to 7. In the current scenario, we are looking for full functional recovery. The concept came because, just read this line in the yellow box, nearly half of the depressed patients who achieve remission do not consider themselves to be in remission. So patient is not satisfied by the means of scale. The clinicians are satisfied that the person is a responder or is in remission. But what the patient wants is full functional recovery. So currently, patient specific functioning and quality of life is also important in defining the treatment success. So it is important to improve functioning, better overall quality of life, lower likelihood of relapse. The common symptoms which are residual after treatment are, you can see, the mid nocturnal insomnia, and the cognitive symptoms are more remain residual rather than the negative self view or suicidal ideations. Now you are treating and you face some barriers to achieving full functional recovery. Are the barriers to full functional recovery may be chronicity of the illness, number of lifetime episodes, length of current episode, comorbid illness like anxiety disorder and personality disorder, somatic symptoms, childhood trauma, neuroticism, substance misuse, and ongoing stressful life events may be barriers. Another barrier is partial response to first line SSRI treatment. It has been said that inadequate SSRI response uh, are associated with increased risk for relapse. Treatment factors can be barrier like inadequate therapeutic dose, insufficient trial of the antidepressant, or the compliance of the patient. So, if all these factors are not there, then one have to see the result of any antidepressant for 3 to 4 weeks at optimized dose and the optimal period of time before shifting to next treatment. So adverse events are also one of the hurdles in achieving full functional recovery. So this is the list of side effects, and the common side effects which are seen in the clinical practice are insomnia, tremor, sexual dysfunctions with SSRI. With SNRI, insomnia, nervousness is the most common. With TCA, dry mouth, blurred vision, constipation, urinary retention, and the sedation. And others are somnolence in the daytime and weight gain, maybe the major concern for the patient and may drop out from the treatment. Decreased sexual drive and functioning is considered to be a bothersome adverse effect related to SSRI treatment. So now the quest for better antidepressant continues, and why? The challenges are not all antidepressants have clear-cut efficiency on severe depression. Poor compliance due to side effects are there, which compromise the chance of recovery. The best fit solution are the antidepressant should have faster onset of action, uh, superior efficacy, decrease the number of patients who have poor or inadequate response, and antidepressants should leave fewer with resistant depression. This is the evolution of antidepressant timeline of evolution, starting from the imipramine in 1950s to duloxetine, escitalopram, and vortioxetine in the 21st century. So you can see escitalopram is also discovered as antidepressant in 21st century. Now coming to the molecule vortioxetine. So vortioxetine is considered as serotonin modulator, and it is first innovated by Lundbeck and approved by FDA, US FDA 2013, and DCGI approval got in 2018. So we will learn why it's a serotonin modulator and what is the meaning of modulator. So it has multimodal mode of action and target three sets of receptors. First is it inhibit the serotonin transporter, SERT, known as SERT, and it acts on several G protein linked receptors known as 5ST1A, 1B, 1D, 5ST7, and the last is inhibition of ligand gated ion channel, that is 5ST3. So now again look at this picture. This the orange figure is SERT, serotonin transporter. So these neurotransmitters in the synapse get back into the presynapse via these transporters. And what the SSRI does, it uh, blocks the reuptake. It acts on these transporter, and neurotransmitter remains in the synapse. But what happens in long term when there is excess of serotonin in the synapse, the autoreceptor gives the negative feedback and further release is reduced in the synapse, and this considered as one of the reason for uh, relapse during the treatment. Patient is on treatment and patient may relapse because of this phenomenon. So vortioxetine blocks this SERT, and what it causes further, it acts on 5-HT receptors, and these 5-HT receptors are these autoreceptors, which are 5-HT1A, 1B, 1D, and 5-HT7. Okay. The transporter blocks the reuptake, and the action at autoreceptor blocks the negative feedback to the presynapse. In the long term, the effect is sustained, is said to be with the vortioxetine. Now, what happens at 5-HT3? 5-HT3 has pro-cognitive properties. Acting on this receptor are said to enhance the release of acetylcholine and norepinephrine, and as a result, there is improvement in cognitive domain. The another mechanism of action is on GABA, and you can see in the last, when glutamate release is enhanced, it can lead to the enhanced downstream release of numerous neurotransmitter, including DA, NE, acetylcholine, histamine, and 5-HT. So by this theory, it is not seem directly involvement of GABA in alleviating the symptoms, but it enhances the downstream release of neurotransmitters. Now the indication of what is vortioxetine. Vortioxetine is indicated in major depressive disorder, yet in adults. It can give with or without food, and the starting recommended dose is 10 milligram once daily and can be increased to 20 milligram per day. Consider 5 milligram per day for the patients who do not tolerate the 10 milligram of dose. And the beauty is this drug can be discontinued abruptly. Half-life is 66 hours. The Tmax gained in 7 to 11 hours. Bioavailability 75%. It is bound 98% to plasma protein and extensively metabolized by cytochrome P450 2D6. Excreted 59% in urine and 26% in feces. And food has no effect on bioavailability, can be taken without any regards to food. In special population for pregnancy, lactation, and pediatrics, no adequate safety data is available, and it is not yet recommended for this population. But in geriatrics, no dose adjustment is required. In hepatic impairment, dose adjustment is not required. In renal impairment, dose adjustment is not required. So it is safe. It is a safer drug in geriatric population and with hepatic impairment and renal impairment till now. Now the few clinical evidence for the drug. In the short-term studies, 6 studies have been done simultaneously, and you can see in this bar graph in study 1 to 5, it has superior efficacy against the placebo, and with 15 and 20 milligram almost same effect is seen. In the last slide, in the last study, this had been done in elderly against the placebo, and the vortioxetine found to be effective in alleviating the symptoms. So in terms of responder rate against the placebo, what is the responder rate? Responder rate is uh, score on MADRS either 50 or less than of it. So at vortioxetine 15 mg, 50% of the patients responded, and with 20 milligrams, 61 had responded, while 32 responded with placebo. In terms of remission rate, with 15 milligram of vortioxetine, it was 34%, almost 35%, and with 20 milligram it is 38%. Remission rate means MADRS score less than 10 or equal to 10. In long-term study, this is a 52 weeks study and studied at 24 week and 52 week. The responder rate in at the interval of 24 week was 49% and 60% at week 52, and remission rate was 55% at 24 week and 61% at 52 weeks. Similar responder rates means MADR score of less than equal to 50 or in remission less than equal to 10. So what about the relapse prevention? Patient is recovered and against the placebo, it has been seen that the 5 milligram of vortioxetine had 19.3% of relapse, vortioxetine 10 had 17, and vortioxetine 20 had 70% of relapse rate, uh, while placebo had 32% of relapse rate. Impact on cognition, you can see in both the measurements, the cognition is enhanced with vortioxetine more than the placebo, whether it is significant or not. And in this study, the vortioxetine 10 mg had seems to be have significant raise in the cognitive symptoms, the improvement in the cognitive symptoms, and with 20 mg, it is also seen in the 50% of cases. Now look at the sexual functioning. With vortioxetine, 45% of the patient improved, while with the escitalopram, it was an head-to-head study, while with escitalopram, 42 uh, percent of the patient had 42 was the score of on CFSQ with the escitalopram and 45 with the vortioxetine. Impact on sleep measured on PSQI, ISI, and ESS. You can see it is reduced on PSQI score from 11 to 9 at 8 weeks, 15 almost 16 to 12 in 8 weeks, on ESS 8 to 6.5. It has a positive role on sleep also. Now you are giving some other antidepressant like SSRI, SNRI, and now you want to switch the patient to vortioxetine. So how can you do this? This is the bar diagram. Uh, this is the impact on uh, overall functioning, which is reduced by 29.8. The p-value is highly significant. Okay. This is the change from baseline in Oxford Depression Questionnaire. At 8 weeks, the overall improvement was seen as very significant. So other domains had been calculated for not caring, detachment, positive reduction, general reduction, antidepressant as cause. So in all the domains, the higher improvement had been seen. So for vortioxetine, it improves overall functioning. It reduces overall depressive symptoms, improve emotional blunting. It improves motivation and energy, and cognitive performance becomes better with vortioxetine. So effect on body weight. In long-term study, you can see only 0.4 kg of weight with 5 to 10 milligram of vortioxetine had been seen, and it is non-significant in 6 to 8 weeks study, which is 0 kg. Discontinuation rate in comparison to placebo, the vortioxetine 15 and 20 mg had 8% of discontinuation rate. Now comparison. This is the comparison done for number needed to treat, number needed to harm, likelihood to be helped or harmed against duloxetine, escitalopram, levomilnacipran, sertraline, venlafaxine, and vilazodone. And number needed to treat is seems almost same with the other drug, and number needed to harm is maybe significantly higher for vortioxetine. This means this much number of patients are required to be treated when a harm can be seen in a patient. So safety, tolerability, and dosing frequency. Uh, Vortioxetine causes 0 to 5% of sleep disturbances. Weight gain is 0.4 kg in long-term studies. There is no significant effect on sexual functioning with the vortioxetine, and dosing of vortioxetine is OD, once in a day. Now coming to the switching vortioxetine from other drugs, here is a chart which shows that direct switch is possible from SSRI group and fluoxamine also. Direct switch is possible from venlafaxine, duloxetine. Stoppage of previous drug is required in case of fluoxetine and agomelatine and clomipramine. Cross tapering is required in case of when the patient is on mirtazapine and reboxetine. In SSRI, caution should be taken for paroxetine use. Now, summarizing the talk, it's a novel antipsychotic. It has multimodal serotonergic agent, approved for treatment of MDD in adults. CanMat recommends it as a first-line antidepressant at 10 and 20 milligram of doses, likely to be used in patients who do not respond tolerate to an SSRI or SNRI. There is reduced risk of relapse in remitted patient, improve cognitive functioning, level 1 evidence for use in MDD with cognitive symptoms said by CanMat, no effect on sexual functioning, improved treatment emergent sexual dysfunction is also seen with vortioxetine. No QTC prolongation is there, especially useful in the patient develops sexual dysfunction, weight gain, or cognitive dysfunction. No dose titration is required. Convenient once daily uses can be stopped abruptly without discontinuation. So vortioxetine achieves remission, it improves cognition and overall general functioning. Vortioxetine fulfills all the needs of 21st century depression patient. Thank you.